Good morning. So I'm going to introduce myself. My name is Laurel Rice. And I grew up in a small town in western New York State. It's true, I actually did. It's a very Republican, small little town. And I knew right then that those were not my peeps, other than my family. So that's how we're going to get started here. Kate Menard was supposed to give grand rounds today. She's chief of MFM at UNC, and her mother, ill, passed away. So, I'm here to step in. So the topic, intersection between clinical trials and health disparities. That's what we're going to talk about this morning. I have absolutely no conflicts of interest or disclosures, meaning I own nothing. The learning objectives. We're going to talk about clinical trials in general, a little bit more about GYN oncology. Health disparities in general, a little bit more about GYN oncology, and then where they intersect. Those are the stated objectives, but my real objective for the talk is for the youngsters in the room who are thinking about the next 30 years of their career, because this is actually just a story this morning. It's a story about how I became interested in those topics. Interest is really, really important to follow what you're actually interested in, because when you do that, opportunities come up. And the opportunities come up all the time, but if you have a particular interest in your mind, it seems like more opportunities come up. And I think that's true. So for me, it started with an article by Malcolm Gladwell. He's a prolific writer. I'm sure everybody in the room has read something about him. The Tipping Point's a really famous book. But this is the article that really caught my attention about clinical trials. It was published in the New Yorker in 2002. And the name of the article is John Rock's Error. And a lot of the article is about his relationship with the Catholic Church. It's fascinating. He went to church every day of his life up until a certain point, and I will discuss that point. It also briefly describes everything that the guy has accomplished, and it really was just breathtaking. Superficial discussion in this article, but for example, he figured out ovulation. He worked at the Free Hospital in Boston. He was a Harvard professor for 35 years, and he measured the body temperature of every woman that walked into that hospital every day. There was no IRB, there's no Excel spreadsheet, no computers. He figured out this temperature thing and eventually had a clinic to both help women get pregnant and help women not get pregnant. He also harvested the first egg and studied that, and he's considered one of the fathers of OCPs. Anybody in the room feeling inadequate? I'm feeling inadequate. Anyway, he was a big guy, 6'3". The Catholic priest that married him was the same priest that married Joe and Rose Kennedy. I've already mentioned he went to church every day, and he's kind of a famous dude. And he wrote the sentinel articles in the New England Journal of Medicine on ovulation and the physiology of the human conception. Belonged to every fancy organization. Cover of Newsweek. I mean, the guy had it going on. This is a picture of the Free Hospital, which is where he worked for a very long time in Boston. And this is where he conducted the first clinical trial on birth control pills. He didn't call it that. 50 women, nobody ovulated. I just want to say parenthetically that I lived in that hospital. They turned it into apartments when I was in Boston. So I thought that was kind of cute. Yeah, I had an apartment in the Free Hospital for women. And actually that hospital was built and started for women with cervical cancer because they smelled bad and they didn't want them in the Peter Bent Brigham or the MGH. Just saying. So they had the 50 women, successful clinical trial. Birth control was a felony in Massachusetts. So they went to Puerto Rico. I do know why Puerto Rico. One of his co-investigators was from Puerto Rico. They did a big study in Puerto Rico. Nobody ovulated. So they took it to this conference. This is a very famous conference, an endocrine conference every other year in '56. And they named their project Synthetic Progestins in the Normal Human Menstrual Cycle because felony and also the whole thing with the Catholic Church. Someone got up and said, gee, I think we have anti-ovulation here. Yeah, that's exactly what they had. And by 1959, many, many women were taking OCPs for irregular menstrual bleeding. Do you think women, even at that age, wanted to control their reproductive health? I think so. And it's funny, Searle is a company that was putting it forward, had a warning, you will not ovulate if you take this drug. Talk about free advertising, that's totally awesome. And then they put the application into the FDA in October of 59. And in 1960, John Rock, as well as Dr. DeFelice, presented this to the FDA. Pasquale had just graduated from his residency at Georgetown. And I've already stated that John Rock was very famous even at this time. And apparently they had words about whether the Catholic Church would ever let this fly. DeFelice said never, and John Rock said, please do not sell my church short. So the error, according to Malcolm Gladwell, was that at the time, of course, nobody realized that OCPs was a cancer prevention strategy. That would have helped. So the FDA approved OCPs, 1961, the chair at Yale, and his name was Lee Buxton, and the head of Planned Parenthood opened a clinic. They were arrested and fined. Planned Parenthood, yay Planned Parenthood, took it immediately to the Supreme Court, and they struck it down, and for the first time since 1879, it was legal in Connecticut. And there's a picture of Estelle, who I think is just adorable. And so in 1972, they went a step further. Even women who weren't married could have birth control. Special, very special. Now I want to just point out, I was in high school. Everybody knows I'm the oldest person in the room, but I was in high school during this. Pretty big deal. And then Roe v. Wade in 1973. This is an article I'm thinking most people are familiar with, published a couple years ago in the New England Journal of Medicine, funded by the NIH and the Buffett Foundation. Not an anonymous foundation, but the Buffett. And it talks about the decline in unintended pregnancy in the United States. And we all know it's a metric of reproductive health for any country. And the news is really quite good between 8 and 11. 6% reduction in all unintended pregnancies in the US. I just want to take note that we still stink. In England, it's 16%. In most Western European countries, Australia, it's much lower than the 45% we're enjoying right now. But the drop was particularly noteworthy for teenagers, so that's great. I just want to take note of the fact that not all women enjoy that same drop in unintended pregnancy. If you live below the poverty line in this country, the unintended pregnancy rate is 3 times higher. And if you're Black and Hispanic, it's about 2 times higher. So not everyone enjoys that same rate, that same decline in rate. And the Guttmacher talks about poverty as an important determinant of unintended pregnancies as well. So that's kind of how I got kind of interested in clinical trials. Really started with that John Rock article, and then I thought, oh my, that's interesting. Puerto Rico, it's a felony, just kind of tantalizing. The second phase of my intellectual interest in this is the Women's Health Initiative. This is a study most people are familiar with, 161,000 women. You've got 1 observational study and then 3 controlled trials. I'm not going to say much more than that other than this. This was the first article that came out in 2002. Now, I have to admit, I was in the heat of battle right here. I had 2 kids, vice chair, started a fellowship. It was like I wasn't reading very much at all, other than People magazine, to be totally honest. So somebody came in, I had a clinic, and the wife of the chair of anesthesia came in. This was in like the New York Times. She saw it that morning. And she brought the article, and I immediately left and Googled everything because I knew nothing about what she was talking about. And so the Women's Health Initiative, this was a sentinel event. And you guys know the results of this. It was stopped prematurely because the risk of heart attack, breast cancer, stroke, blood clots was high, and hip fractures and colon cancer was diminished. But I remember thinking, oh, the Women's Health Initiative, I think I heard something about that. It was started in '93. I thought, well, isn't that nice? They have a study just for women. I think that's awesome. That was my real thought after I got over the mountain of realizing I didn't know anything about it. And a lot has come out of this Women's Health Initiative. Look at the number of publications. It's really generated a lot of data. So I got vaguely interested in the Women's Health Initiative, just kind of philosophically. So I kind of thought about comparing it to other NIH projects. And you can see in terms of numbers, it's bigger than the Harvard Physicians Health Study, smaller than the cancer prevention trial, and in the same ballpark as the prostate, lung, colon, and ovary cancer or screening trial. Okay, but what about the money? Like, how does it compare to other NIH-funded big projects? And this data is data from when the Women's Health Initiative was completed. And so the original budget was 140 million. Of course, they spent 645 million. Klaus, what do you think of that? Not good, no. Classic. But you can kind of compare it to other studies that were being done. It's not huge. The other ones are bigger, but it's not totally nothing. So that's good. So let's digress for a minute. So clinical trials, the Women's Health Initiative. In the 60s and 70s, women were actively discouraged from being in clinical trials. Prevented, I think you could go that far. Just for a frame of reference, home pregnancy tests were available in 69. So in 1986, like just keep this history thing in your mind, the NIH put out a policy encouraging investigators to include women in clinical trials. That's a very cheerful word. Encouraging. I like that. It's like, okay, yeah, maybe we'll think about that. But why would women be excluded from clinical trials in the first place? First of all, everyone is overwhelmed with a menstrual cycle other than us. It's actually absolutely true. That is a thing of grace and beauty. 2016, we're in 2018, this was published in Popular Science. 2016, women are being excluded because we just don't understand the menstrual cycle. Okay, all right, good to know. And then other reasons would be, okay, it's expensive to do gender-specific hypotheses, more costly, childcare, yeah, well, there's money, it's always the money. But I just want to speak a little bit too. There was general fear because of this incident that happened with thalidomide. Now, thalidomide is a drug. We use it in cancer trials, but at this point, it was prescribed to women who didn't feel well when they were pregnant. 10,000 babies born in the world with flipper-like wings, cardiac defects, none of them in the US. And I remember the cover of Life magazine. It's the only magazine we got at home. It wasn't exactly this picture, but I remember thinking, oh my God, what happened here? That baby has no arms. So this is Frances Kelsey, MD, PhD. She got her master's in pharmacology at McGill and her MD, PhD at the University of Chicago. When she showed up, they thought she was a guy. She was actually a girl. They were shocked. There was no pictures in those days, apparently. So anyway, after she graduated, she and her husband moved to one of the Dakotas. Sorry, Klaus, I don't know which one. And they're all the same to me, you know that. And they practiced for 20 years, had a couple kids, raised them. And then 1960, they moved to DC. Remember, she had a PhD in pharmacology. And her first assignment, because she went to work for the FDA, was to review the application for thalidomide. I am sure she was the only woman at the FDA at this point, been approved in 20 countries, huge pressure from the pharmaceutical industry, and she said, no, there's not enough information. Well, that worked out well. People, in short order realized, yes, she actually is a heroine, whatever. And she also received the President's Award for Distinguished Federal Civilian Service. She had job security. She stayed at the FDA till she was 90 years old, fully employed. Nobody's going to fire her, I can tell you right now. And I don't know about everybody else in the room, but I read the obituaries in the New York Times compulsively because it's like 90% of them are just fascinating. And of course, she showed up in 2015. Impressive woman. So let's go back to this 1986 encouragement thing. So 4 years later, the General Accounting Office said, oh my God, nobody's done anything here with this encouraging thing. Now, when you hear the word General Accounting Office, don't you kind of think about accountants and like bean counters? And oh, that's probably a friendly little group of people. No, 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 no. If you right now start reading, when you read the paper and you just look for General Accounting Office, these people, They got it going on. They're the ones calling Pruitt out, charging him with the $43,000 he spent for his office. So it's a powerful organization with a very lame name. They should call it like a honey badger thing or something, because they are. So this report from the General Accounting Office basically said, look, there's been no improvement. And the whole issue with the General Accounting Office coming forward was prompted by the Society for the Advancement of Women's Health Research, which was founded in 1980. And there was a small posse of individuals whose names keep coming up and up and up. Pat Schroeder, Olympia Snow, Henry Waxman, they were tenacious. And I want to tell you that Gloria Sarto was in the fray as well. She's sitting back there being demure. Don't be demure, Gloria. And it led to the Office for Research on Women's Health at the NIH was in 1990 that was established. And basically what they said is, why are there no women in clinical trials? All the work is being done with men, and even then they knew it's like men and women, metabolism, things aren't exactly the same. So it was brought forward, and this was part of the bully pulpit. The Harvard Physicians Health Study, aspirin heart disease, all men. Multiple risk factor intervention trial, all men. Baltimore longitudinal study of normal human aging, all men. And then the counterpoint was, well, you got the nurses' health study, and that was a level 3 study, observational only. So there was some, this is a real thing. So how did the NIH respond to the General Accounting Office calling them out? They said, okay, we're not going to give anybody any money unless they include women and minorities. And they started the Women's Health Initiative. So it wasn't purely pureness of heart that got the Women's Health Initiative going. I would put it more in the guilt, fear category, whatever. You just take whatever you can get. So that's vaguely interesting. And then it was also helpful that in 1994, legislation was passed saying the same thing. Women and minorities have to be included in clinical trials. 17 years later, the Institute of Medicine here, and this is in 2010, said mission not accomplished. Still not enough women and minorities in clinical trials to make the data useful. This is Francis Collins. He's head of the NIH, still has his job, which is great, I guess. And so he wrote a paper in 2014 with Anita Clayton, who's the chair of the Office of Research on Women's Health. And in this article, I'm just going to grab out a few points. He states that, listen, we've got the clinical trials thing done. That's perfectly even between men and women. The reason our research is not reproducible, so now they're talking about the quality of the research, no longer talking about men and women in clinical trials. Digress, move the attention, is because we've been using male mice and male cell lines, and we're not going to do that anymore. That's a charge to everybody doing research. And of course, the lay press picked this up a lot. This was a few years ago. This was published 2 weeks ago in the Wall Street Journal, talking about how bad is the government science. And Amgen is a company, it's a pharmaceutical company. I think they make Ob-Gyn. I'm not sure, I'm pretty sure they do. And they took 53 landmark studies in hematology and oncology and did them again. How much money do they have? More money than God. And only 6 of the 53 they were able to reproduce. So we have a big problem in this country in terms of the quality of our research, which is a little bit separate than what I'm talking about, but still relevant. So in 2016, the NIH put out another missive. We got to have male mice, we got to have male cell lines, or you're not going to get the money. We'll see how that goes. So all of that, back to me, generated some real interest on my part. And again, speaking to the youngsters in the crowd, you got to follow what you're kind of interested in. This kind of made me mad, to be totally honest. So I wrote this paper with Marcella Del Carmen in the Green Journal, and we summarized this whole topic in terms of clinical trials in women in general, and then specifically about GYN oncology. So I want to say a word about GYN oncology. Leading into 2005, enrollment in GOG trials, gynecologic oncology group, was impressive. A lot of great work got done during this time period. We figured out the chemotherapy helped radiation, figured out IP chemo, big trials. It was great. But what happened after that was a 90% reduction in enrollment and a 68% reduction in available trials. That's what's going on in GYN oncology right now. And there's reasons for that that aren't totally crazy. You know, the NIH budget's actually flat, went up a little bit, whatever, not that much. And then they restructured the NCI-sponsored cooperative groups, and we were lumped in with NSABP, the breast and colon folks, as well as RTOG, which is the radiation therapy groups. And of those three, we are the small group. Remember, there's only about 2,200 GYN oncologists in the United States. And the NIH, NCI has changed their focus to smaller, personalized medicine-like studies versus the big clinical trials. So I want to spend a minute and talk about this paper that Ryan presented at the SGO a few weeks ago. And it speaks to this issue of, gee, are women's cancers getting the same amount of funding as men's cancers? And this goes to the lethality scores, meaning like funding to lethality. Are we getting the same amount of money, relatively speaking, as other male cancers? And so, again, analyzing the amount of money that's spent on this female cancer research. So how do you figure that out? You know, incidence, mortality, burden of years lost. All of those things are important if you're trying to figure out whether the money's right. You can't use one of them. For example, breast cancer is really common, but the mortality is actually quite low compared to, say, ovary cancer, which isn't even on the list of the top cancers, but it's number 5 for cancer deaths for women. So, a metric to standardize the impact of mortality, incidence, and impact on lifespan. Data was analyzed over a 7-year period, mortality incidence from the SEER registry, which is a big national cancer registry, years of life lost per cancer death from the NCI, and then funding information from the NCI. So, a little bit about the math. Mortality to incident ratios, cancer burden on a population, that's not hard to figure out. Person years of life lost per cancer case. And we converted that to a rate per 100 case because it's more standardizable. I made that word up. So take a look at this. This is ovary cancer compared to prostate 2014. You can see the numbers for mortality. You can see the numbers for incidence. And the mortality to incidence ratio is at the very bottom. You know, comparatively speaking, ovary cancer, more people die than prostate cancer. So if you take that mortality to incidence ratio, and you then take into consideration years of life lost per new cancer case, years of life lost per 100 new cases, you can get down to a number that's actually helpful. And for ovarian cancer, the funding to lethality score is 0.085, and for prostate cancer, it's 1.146. So I think that kind of says it all right there. And this is a summary when you actually look at the dollars allocated to the NCI for research in these two cancers. So the funding to lethality score is really just not quite balanced here. And if you take the aggregate over 7 years for these 13 cancers, ovary, cervix, and uterus are right at the bottom. So the strengths, reliable data from a single source, nationally represented sample, trends are observable. The weaknesses is not all the research comes from the NCI, we know that. Unable to determine the contribution of cooperative groups, and there are funding gaps. Just a word about not all research coming from the NCI, that's most certainly true. And pharmaceutical companies can decide what they want to fund by themselves, but the NCI is us. We pay taxes in this room. So the conclusion is that uterine, ovarian, and cervix cancers are disproportionately underfunded, and the trends are not improving, and this is being picked up by the media. I would hope so. My only question is, since the SGO was the end of March, why is this not in the New York Times now? But I think we all know the answer to that. It's not all doom and gloom. As everybody in this room knows, I'm kind of cheerful, always looking for that silver lining. And for GYN cancers, yeah, we got it going on. You can see the downward trend in the blue, the upward trend in the orange. The GOG Partners is part of the GOG Foundation that funds industry-sponsored trials. Got to go to a different door, knock on the door. It's not going to be the NCI. And so Larry Copeland and Robert Mantle are running that. They're doing a great job. I feel optimistic. You know, GYN oncologists are a nimble group of people. And there's much more than that. The SGO has taken on a very broad platform. This article summarizes work from the NCI GYN Cancer Steering Committee, looking at, you know, where we're going to go in the future in terms of histology and molecular biology, directing our efforts. The SGO has a communication platform nationally that's very comprehensive. It's developed a very broad advocacy group, and really the partnerships that have developed between the SGO, the NCI, the GOG Foundation, industry advocates, it's really, there's a lot of forward motion. So I feel optimistic. Still mad, but optimistic. And it's important to remember that the United States does a really bad job with adult cancer clinical trials. Only 5% of adults are on clinical trials in the US. For pediatric cancers, it's about 25%. You know, I should know the number for other countries, and I don't, so I'm sorry, but that's a pretty low number. It's important to have access to novel therapies when you're diagnosed with cancer. And of course, it's all about the moonshot. And, you know, I've read a lot of articles about this, and basically a lot of the question comes down to eligibility criteria, because in a clinical trial, you're looking for homogeneity so you can get a decent p-value and say something that's meaningful, right? But then, is that generalizable to the general population? So those are kind of opposing forces. Let me not to pretend to be super knowledgeable, but I think that is the major issue. So you can see how I kind of got going on clinical trials. My blood pressure rises just giving this part of the talk because it does make me mad, but that's okay. Turn it into a positive force, not a negative force. So health disparities. Why did I get interested in health disparities? First of all, as I was looking at all of these issues with women in clinical trials, you'd have to be deaf, dumb, and blind to not realize, whoa, underrepresented minorities are, you know, they're in the same boat as we are. And then I also moved to Wisconsin in 2007. This looks at infant mortality in the United States, 2013 to 2015. We look okay overall. But then if you look at African Americans, we are the worst state in the union. You cannot live in Wisconsin and not care about this. You just can't. It's just unacceptable. In little Dane County, we stink as well. So don't think we're special. We are not. So this was published in February of 2018. Black Hispanic lawmakers call Wisconsin the worst place in the nation to raise a black child based on educational opportunities, etc. 2 years ago, this was published in Dollars and Cents. The worst place in the US to be black is Wisconsin. And they have metrics. They look at incarceration, home ownership, child well-being, child poverty, unemployment, teen pregnancy, and poverty. This is the state we live in. This department continues to row as hard as we can. Every single person in this room. I know that. You know that. And we have put not enough effort, but we're doing all we can. First of all, recruiting Deb Arenthal and Jenny Higgins was clutch. Those two women are leading what's going on in terms of pop health on many fronts, but certainly health disparities, birth control, etc. They got a big anonymous donor grant. I'm not going to say more than that for their work, reproductive justice. Recently, they were successful in getting a cluster hire approved by the chancellor at the University of Wisconsin, reproductive justice. They were the top rated application. And they're applying for a huge grant from the CDC. And a lot of that is around health disparities in one way or another. Because remember, health disparities isn't just race, socioeconomic class, gender, there's a whole bunch of things that go into it. We have a community advisory group that's kind of helped launch Centering Pregnancy, although I have to say it's mostly Cynthia Anderson and Kristen Sharp and Leslie Redmond. And McCabe's husband, God bless him. He got us to the March of Dimes. I think he was president or something in Wisconsin. I can't remember McCabe. But, you know, he got us all hooked up in there, and we got a grant from them. Again, this is a tenacious group of people in this room. Nimble, looking for funding. And Karen Mulligan was absolutely clutch with getting a centering program, and we're almost ready to start it on the east side of town at the Y, or the community center. To get Epic in there was nothing less than superhuman. We've all been like on this, like gnawing at this for a long time. And then we've had some great talks in the last couple of years around health disparities. Molly Carnes about implicit bias. Brian Gittins showing us how we all do individually. Melissa Gilliam came up from the University of Chicago. Remember, she gave that talk. And Vivian Pinn, Gloria brought Vivian Pinn in, who was the head of the Office of Research on Women's Health for a good long time. So our efforts, in my opinion on this, is we have to double down. And part of talking about health disparities, Chris John, can you fix that? I got no idea. Everybody knows that I'm technically compromised. But I do think we just need to double down on this. And what does that mean? I think, first of all, and what'd you say? Oh, dear God. 30 minutes, I can't progress the slides? Okay, good. Actually, I could get this talk about slides. So, no, we just have to keep railing on this and talking about it. Part of it is I've noticed this in meetings I go to, like nobody wants to use the word abortion. Nobody wants to use the word racism. Nobody wants to use the word misogyny. I'm good with those words now. I use them all the time. Oh, that's misogynistic. I don't like that. Like people are sick of me over, yeah, well, whatever. I'm not going to keep going. And the other thing that happened, because I think it's because of the efforts of this department, UW spent a couple years figuring out their priorities with their community health platform, Jonathan Jaffrey, Robin Lanton, who came and talked to us. And you know, what's moved forward is they're interested in this issue of healthy mothers and healthy babies. And I just think that everybody in this room should take a little credit for that. Because, you know, it's like building a village around a topic. Nobody can get anything done by themselves. And granted, this centering pregnancy is just one little part of it, but it's raising awareness throughout the university and the state about this topic. So I'm pretty happy with that. As I mentioned, remember, it's not just race when it comes to health disparities. If you live in rural America, your chance of dying is a lot higher than if you live in urban America. And if you look at Wisconsin, 36% of our counties don't have an obstetrician gynecologist, and the female population is growing. So when you think about that, you think, oh, yeah, living in rural America would not be so good. Which brings me to the first rural residency slot in the United States. Go Ellen, go John, go Jody and Maria and Becky. You guys have done an awesome job. And it's certainly, I mean, it was just so much work to get this going, getting the money, getting approval, getting the ACGM approval. And I want to just tell a small story about this. And I don't know if I've told you this before, but one morning about 5 a.m., Chip and I are getting ready to go to work, and he's mumbling about a rural residency program that got approved for general surgery, family medicine, and pediatrics. I thought, huh, why aren't we in there? And I was relatively cheerful at that point. I just got the piff. I said, can you send me that? I sent it to Ellen immediately. And you know what? That was very helpful. Now, of those 4 rural residency spots, we are the only one that is not getting a level of funding from the state, even now. And that's in the face of maternal mortality in the United States going up, except in California, which is a special place. So maternal mortality is going up. We have this horrible African-American infant mortality rate, and we are the only rural residency spot in the state of Wisconsin that isn't getting the same, it's not getting the same level of funding. So I'm calling out misogyny on that. That's what I'm talking about. Now, as it turns out, there's a silver lining in everything. When it came to the effort to maintain our abortion training for our residents, this issue of rural Wisconsin not having obstetrician gynecologists, and the fact that if our residency went down, the number of women serving this state, because 40% of our residents stay in Wisconsin, that's right, Ellen, isn't it about 40%? This would be a problem for the state. So the bully pulpit here was one of serving the state of Wisconsin. And it really helped that we had that rural residency thing going. And that was really a very important part of our bully pulpit. And then just going back to this thing for thinking about opportunity and where your interests are, when I was president of the SGO, I got to choose the topic for the special edition of Gynecology. They do that once a year. So I chose health disparities. You see, when you get interested and committed to something, things just kind of show up, more so than if not. I believe that. And this is one of the very best articles from that journal. And it talks about gynecology, of course, because it's a gynecology journal, but it's translatable to every kind of health disparity possible. It spends a little time talking about cancer, most of the time talking about the framework around which to think about health disparities. It's short, you should read it. And the woman who's the senior author is Kemi Dahl at the University of Washington. She recently got a PCORI grant looking at endometrial cancer in African American women. The mortality rate for endometrial cancer for African American women is much higher than it is for white women. And she's attacking this by all the important ways that you can, in my limited fund of knowledge, that work, engaging the patient, community support, education, research, clinical care. So I think, and the SGO did partner with her on this, again, thinking about opportunities and what shows up. So the intersection between the two. When I think about clinical trials, I think about, can I actually say to a patient, if you enroll in a clinical trial, your outcome will be better? No. And does a health disparity exist? Does health disparities exist for clinical trials in the United States? So I think in terms of this issue, if a patient asks you, or it even crosses your mind that, the outcome will be improved if I'm on a clinical trial. I think this is the best article out there. What the authors did, and this is from the Hutchinson Cancer Center at the University of Washington in Seattle, they took 21 SWOG clinical trials. SWOG is Southwestern Oncology Group. And they divided those clinical trials with about 6,000 patients into good prognosis or bad prognosis cancers. They took the arms from those clinical trials that were the standard arms, not the investigational arms. So they took out the women or men that were getting, like if you think about ovarian cancer, platinum Taxol. And they didn't deal with the patients that were getting platinum Taxol and some investigational agent. They just took out the patients on the control arm. And then they matched them to patients from the SEER cancer database for all the important demographics. And so what they were trying to get at was, if you just enroll in a clinical trial, are you going to do as well as the women that are getting treated in the SEER database? So that kind of summarizes what I just said. They applied great statistical methods. As I said, there's about 6,000 patients. And here you can see the good prognosis trials and the bad prognosis trials. And if you were in the good prognosis group, there was no difference than if you're in a clinical trial or not. If you were in the poor prognosis difference, there was only a difference up until 1 year. So what does that mean? It probably means, first of all, you can say there's no difference in general, and that 1 little year of improvement, eligibility criteria that excluded higher comorbid patients, probably. So again, it goes back to this topic I mentioned about homogeneity in a clinical trial versus generalizability. That's one of the big things with a moonshot. It's like, can we have some research that applies to the whole population? So that answered that question for me. And then in terms of minorities and women in clinical trials, I want to refer you back to that article in 2015 by Francis Collins, where he says, oh no, we're good on the clinical trials. We got that. We're all equal up. So this is a review of 304 peer-reviewed publications, and I'm going to talk to the 277 about the treatment trials. And what they did was they took a study that was published in 2000, and they applied the same criteria to get a control group to 2001 to 2010 to see if there's been any improvement in the enrollment of minorities and women in clinical trials. That seems smart. And here's the data. In terms of including race or ethnicity, there was an improvement from 36 to 51%. But number of participants It actually went up for Hispanics, but it went down for African Americans. And it's still mostly white. In terms of gender, a slight increase of articles that ask whether it's male or female, but you can still see it's, men are represented more than women still. So the conclusion of that study was actually there's been little to no progress at all. I don't know where Francis Collins came up with this data. And I think there's a lot of work to be done. This is an article, I'm not going to say anything more about it because I want to leave a lot of time for questions, but it was recently published summarizing the plan of the 4 major cancer groups in the United States, ASCO, American Cancer Society, in their approach to including women and minorities in clinical trials. So wrapping up with where I started, my interest in health disparities in clinical trials, I wish I could say to you that every move in my career has been strategic and well thought out. That just makes me giggle, actually. But I think the principle of following what you're kind of interested in, like when I wrote that article in the Green Journal, I hadn't been elected to be the president of the SGO yet. It was just because I was just interested in that. And so then when I had the opportunity to do something with health disparities at the SGO, it was just completely natural. So that's what I have to share with you today. And I'm thinking maybe there might be some questions. Do we have any questions? Answers? Oh, you're going. Guys, questions, answers? Oh, you're all going to stay mute? That's just great. Joel?
Is there any data? Is there any data as to patients offered enrollment in clinical trials, and what's the uptake in that offer based on race or socioeconomic status?
Oh man, that's such a good question. Yeah, there's a big difference. And Kemi Dahl talks to that a lot. Like African American women, other minorities are offered less frequently. It's hard to get to the data because you got to understand the population of where the clinical trial is. Like here in Wisconsin, we don't have that many underrepresented minorities. But it goes to a principle that was summarized in an article published a couple years ago. And a lot of that, the article I'm going to mention is about access to health care. But there was an article presented at the SGO about access to clinical trials. So you could look at both of those as a metric of dealing with health disparities. The article that I'm thinking about in terms of access to health care was published by Rob Bristow with, he used a database, 20,000 women, something like that. And the question is everyone in this SEER database receiving NCCN guideline care for advanced ovarian cancer? Because you can get that out of that database. And if you're Black or poor, the answer is no. You do not receive NCCN guideline care. That's just standard surgery, chemo, nothing fancy. Now, the article on clinical trials, it didn't answer the question of offer enrollment because the study was done in Georgia and they had a very aggressive approach to recruitment. But the principle of access to clinical trials was pointed out in that as, again, a representation of health disparities. Now, I think the article, one of the last articles I talked about in terms of talking about race and then enrollment, that actually kind of answers the question a little bit, but circuitously. So actually having prospective data regarding that, no. But I think you could extrapolate without any struggle at all based on those 2 or 3 studies. Yeah, Mary.
Thanks, Laurel. Great talk.
Thank you.
Do you have any, in the infant mortality disparity between African American and other population groups in Wisconsin is, profound. We all are very embarrassed, I will say, to not be making more of a difference, but yet we are very much with Deb, Jenny, and all addressing it. My again, following my path, as much as I care about infant mortality, I care about the mothers. And I'm curious, do we know in Wisconsin or even in our more local region what the difference in mortality is for underrepresented minority from our GYN cancers?
I don't know that. Ryan, do you know that?
The Wisconsin has a state cancer registry you can just go online and look at. And I've generated graphs from that show at a younger age in certain GYN cancers, the numbers don't diverge so much from black and white. But as you get older, the mortality rates diverge significantly as time goes on and age increases. So the answer is yes, there is a disparity in mortality rates in GYN cancers in Wisconsin alone. Oh, you want specifically from our division? One could gather that data. The problem here at the University of Wisconsin in our group is we see a handful of Black women a year with each cancer. So most of that data is going to come from the greater Milwaukee area when you look at a population. And so it's challenging here to amass enough numbers to have any sort of meaningful data if you only go back 5, 10, maybe even 20 years here in our group. But one could do it.
Harry, that's a good question. My question, and Ryan and I have talked about this, is so we have all this information about health disparities in cancer. Let's just talk about cancer. And we have a great study that shows, gee, if everybody just got NCCN guideline care, which is not imaginative. So what I want to know is with that data, and you could do this with other cancers, it doesn't have to be GYN, a major cancer center could prospectively take a group of individuals with a cancer, colorectal, I don't care what it is, and prospectively march them through and see who drops off for NCCN guideline care. It's almost certainly, a lot of this is social determinants of health, transportation, et cetera, et cetera. There's a ton published on that, and Kemi Dahl speaks to that quite effectively. But like in my mind, that's the next step. So we know they're not getting it, so what are we going to do? We need to do something, not just talk about it. I kind of feel that happens with, a lot of these topics. And part of it is it's big, it's overwhelming, but just nibbling at it and looking for those opportunities to make a difference, like all the work that Jenny and Deb have done with getting grant money and the centering. You do the best you can. But like with cancer, I just keep wondering, that paper was published in 2015. Seems like there should be a plan for, in doing it in the context of investigation, like, okay, we're taking every woman that comes into the UW Cancer Center with cervical cancer, and we're going to figure out why women don't get NCCN guideline care. That's just a perfect study. Okay, that's all I'm saying. Okay, Brittany.
presented to us at the end of my 4th year, and it was pretty amazing at the difference that it made.
Yeah.
And it cost a ton of money up front, but then the sort of it gets made up with time. And a lot of it was patients were very afraid to go to the big cancer center and get their treatment and follow up, and they didn't understand. And when they had people in their own community sort of help them through that and get them the transportation, they went to the visits and they got the care, and their outcomes were better. And I would imagine with clinical trials, it may be similar, because a lot of those same people are very skeptical to sign up for research based on what they've heard about the medical industry and history. And so I think that's something that I've really been interested in, is just how do we get people in the community to help us get people to see us, because we as physicians, especially I know me as a white physician, I'm not going to be able to necessarily get through to those same people the way their community can.
That's Brittany, well said, and it was Partridge he did a great job. And Kemi Dahl speaks about navigation being one of the most important ways to attack some of this. Ryan, did you have something, honey?
Yeah, I just wanted to say we've not done it in cancer, but it's known in other diseases that have done clinical trials looking into what are the roadblocks to enroll patients. And one of the roadblocks to getting into a trial and staying in the trial is that being on a trial requires more. It requires more time, it requires more visits. And we've got someone who has to take 3 buses to get from downtown Milwaukee to the cancer clinic more times. They don't have childcare, they don't have ways to get to the bus, they don't have the time to dedicate. A 20-minute car ride becomes a 2.5-hour bus trip. And so many other disease sites have shown that enrolling people in clinical trials, that's a major barrier, is the resources that are allocated to help get them to the actual trial site.
In fact, Joel, that study from Georgia had as an independent variable distance from the medical center in terms of enrollment. Yeah, Dave. Yeah, Katie. Stairmaster.
A couple points, just comments. Is this on? Yeah, it says it's on. So if you're, interested in this topic, particularly of women not enrolled in clinical trials, what you don't realize as an OBGYN, we don't get the perspective that everything we do, every patient we put on trial helps with this issue. From the outside, people see that. So, for example, in the cancer center, they want people on GYN trials. In the medical school, they want this department to be doing more clinical trials because every patient we put on helps with that balance. And I just wanted to sell that in terms of, you mentioned all the things that you have done towards this effort. I don't know that you mentioned enough about what you've done to help build it in this department. So
well, Dave, that was mostly you, so you go, boy. Tell us about it.
Well, I just want to say that we're at a point. We're at a point now where it has taken a couple of years to build infrastructure and get things ready so that we can start really putting patients on clinical trial. We can start having our resident projects be clinical trials if we want them to and have them be more complex. We can have our young faculty be able to be supported. And we didn't have what we needed to do that, but we have it all now. So, starting in this next fiscal year, starting in July, we should be able to support a lot more trials. And we've done all that for the reason that you just stated. I mean, we need this. The medical school didn't have this because we weren't doing it for them. And now we can do that for them. You also help bring the study called All of Us to this department, which is a big NIH trial, which is being done all around the country. And we're going to be, as a department, helping to put people on that trial. We'll talk about that at a later date. But it's the reason they came to us is because our access to Menard Hospital, to women, to minorities in the communities that we take care of, and they trust us because we take care of their, deliver their babies and take care of their families. So I don't want to take too much time, but I really just want to make this case that this is why you have put the energy into making sure the department is going to be having what it needs to do clinical trials, and we have that now.
Dave, you're being falsely modest. He did all the work, just saying. And that's an important point. I'm sorry I missed that in the presentation. I think this department is perfectly poised to make a big difference. All of us have huge day jobs. There's no doubt about it. So you got to just push it forward as much as you can. But this thing about clinical trials and health disparities is important. And then this thing about African American infant mortality rate. When you tell people in your general life that Wisconsin is the worst state in the union, people pause. Meaning like, and it's not something we want to be known for, but on the other hand, I'm arguing here today that the more you talk about it, like, the better, because I do believe that UW brought in African American infant mortality rate because of all the work that this department has done. It's pushing the ball forward a little bit every day. Yeah, Gloria.
Given the Affordable Care Act and what's happening to it.
Oh my God, Gloria. Don't bring us down here. Don't bring us down. We're going for positive. Oh, sweet Jesus. No, I'm not even going to talk about that. I mean, I was talking to Rebecca Gee yesterday. She's an obstetrician gynecologist who's head of public health for Louisiana. I mean, that's like a huge ass job. And she just got into the National Academy of Medicine. I mean, I recognize her name. It's a long story how we got hooked up. But she just had to call 20,000 people and tell them that they no longer had Medicaid coverage. So when it comes to what's going on in this country right now, research is kind of bottom at the bottom. For a lot of people, it's not about research, it's about trying to get some health care.
And a comment.
Go,
Wait,
yeah.
please. I think to follow minority populations is really important because I think now people are more aware of the fact that breast cancer in African American women is much more aggressive than Caucasians, and also that it occurs at an earlier age. So that when we're looking at screening, I think we have to have screening varied according to
Yeah.
The
Yep.
minority population.
Yep. In fact, again, Kemi Dahl mentions that in her paper. I highly recommend that paper. And I want to wrap up with just, again, hitting the bully pulpit on everybody feeling comfortable in their daily activities when it's appropriate, in the appropriate context of conversation, not just random. You can use the word misogyny, and you can use the word racism. People, I firmly believe that it's just like, it's so obvious. I mean, you're not like saying anything that's everybody doesn't know about, so whatever. Thank you very much. Have a good day.